Our next speakers are Dr. Diane Jette, Associate Chair and Professor of the Physical Therapy Department at the MGH Institute of Health Professions, and Mary Stilphen, Senior Director of Rehabilitation and Sports Therapy at the Cleveland Clinics. So welcome.
Thank you. Can you hear us? We're both going to stand and talk out of one mic. Can you hear me okay?
You can hear us?
Yep.
Okay. Because we're just going to tell you a story, and we're going to kind of tag team with each other.
And we're going to try really hard to keep you awake after lunch.
Yes. So as a little aside, I had a course on health policy last spring, and my course was from 2 to 4 on Friday, the last class of the week. So I know how to keep people active and engaged when they really just want to kind of drift off. So this is our
Yep.
slide. Okay, we're good. All right. How do we advance it? Okay, we just got to do a little technology
There we go.
check here. Okay, we'll do that. So go ahead.
Okay, well, so the story, I have to start my story by telling where I'm from. And so I'm from the Cleveland Clinic, which is an academic medical center, but it's also part of a health system. So within our health system, we have 8 community hospitals that make up our health system. And that all started in about 1995. In about 2010, we decided to integrate all of the therapists within the health system under one leadership, which we call Cleveland Clinic Rehab and Sports Therapy. So we have therapists that take care of patients at main campus in our 8 regional hospitals. We have 100 acute rehab beds. We have 85 skilled nursing beds. We have over 3,000 acute care beds. And we have 47 outpatient locations geographically situated throughout Northeast Ohio and one in Las Vegas. And then we have a team of therapists that take care of our patients. And so we have about 700 rehab professionals that make up the team that make up Cleveland Clinic Rehab and Sports Therapy. So part of our integration really revolved around, when we integrated, we wanted to make sure that we could provide consistent services to our patients, right? So with that came the development of care paths. And with that came the standardization of our outcome measures and outcome tools. And so at the clinic, that's a very important thing for us. We collect a lot of data. The organization has known to collect a lot of data. So that was really important to Cleveland Clinic Rehab and Sports Therapy. So again, starting in about 2010, we have this unified brand. We have a unified organizational leadership structure. We can start to leverage our critical mass, right? We have a voice within this big organization of 700 rehab professionals. We started to really, like I said, we started to standardize our clinical practice, our operations. We were positioned for growth, but we still had to pay attention to productivity, efficiency, and cost structure, just like everybody else. So at about the same time, we implemented a new EMR for just the therapy component within all of our hospitals. And for the first time, we had the ability to collect discrete data. We had been documenting in Epic in the main campus of the Cleveland Clinic, but it was just a text blob, so we really couldn't collect any discrete data. So we had a progressive rollout of our EMR, and it was MediLinks between April of 2010, and it was completed by May of 2011. And again, the observations in MediLinks allowed us to collect discrete data, which was a brand new concept for us. So we started to think about what kind of data do we want to collect, what kind of questions do we want to answer. And so we looked around, so we had some initial goals. So we wanted to collect meaningful, standardized, discrete outcome data with every patient encounter. And again, remember, we have this army of therapists that are working in the hospital, so we have the ability to collect a lot of data. So we knew we wanted to use the data that we collected to help us improve our operations, provide better clinical care. And really at the forefront of this then was that we wanted to see if we could make better decisions about how to make recommendations for post-acute placement, right? The thought was there was a lot of variability amongst the clinicians on what they would recommend for our patients in terms of post-acute care. So that was kind of at the forefront of our thinking. So what were we looking for in a tool? I mean, it was pretty important that we wanted something that was going to be minimal burden on therapists, something that we could collect for every patient, every visit, every therapist. And so it had to be minimal burden on patients also, right? We knew we wanted no more than six questions because our medical director liked the sound of 6 clicks because it was a new EMR. He's like, thought it would be kind of catchy, so 6 clicks, so 6 questions. And we wanted to incorporate items that the therapist already collected as part of their care. So we looked around for a tool. We really couldn't find one that we liked. So Dr. Frost contacted Jette at Boston University. And he said, so we looked at the full AMPAC, and we said, could we take some of the questions, 6 to be exact, 6 questions from the full AMPAC, and create a short form that we could use in acute care? So lo and behold, we did. What we liked about it is that there was 2 domains that we could use, the basic mobility and daily activity, so PT to basic mobility, OT to daily activity, and that there was literature that said that this could be answered as a surrogate. So the therapist was going to answer these questions as a surrogate for the patient. And so I thought I had this slide fixed, but I don't. So the 6 questions that the therapist answers are turning over in bed, supine to sit, bed to chair, sit to stand, walking in a room, and 3 to 5 steps to the rail. Okay, so we answer these questions as a surrogate for the patient, scoring them 1, 2, 3, or 4. 1 is they are unable, 2, they need a lot of help, 3, a little, and 4, none. Okay, OTs do the same with feeding, oral facial hygiene, dressing of uppers and lowers, toileting, and bathing. So this was implemented with minimal instruction to our staff, and I think that's really important. We first we ordered pizza, and we did it over lunch, and we said, is there any chance you guys are interested in collecting functional data on our patients? And they resoundingly, yes. They wanted to collect this data. They wanted to participate. They wanted to know what the functional level of our patients was. So that was it. We showed them the slide that I had just showed you. These are the 6 questions you're going to answer. This is the format. It was in the EMR, and this is how you're going to answer them. So again, the clinician determines the score for each item, either by observing the patient's performance or using their clinical judgment if they haven't assessed stairs, for example. And then they enter it into the patient's EMR.
I'm just going to add something about a study that actually some of my students did. It's a qualitative study. They asked the therapist about implementing 6 clicks. So what's their perception? And one of the things that came out to us is that they were universally accepting of the addition of these measures to their daily routines. At the same time, they didn't really know what it was going to be used for. They said management wanted the measurements, and maybe it would be used in research, and it could help us to track our patients. So there was a lot of goodwill behind implementing this, which I think earlier today we had the question of, do you beat the therapist over the head? And there was none of that in the qualitative data that we got from the therapist. It was really quite remarkable, and I think it may say something about their leadership.
Well, and management didn't know what we were going to do with the data either. So much so that it was hidden in the bottom of our note because we were afraid somebody might ask us what this meant. And we had, I'm not kidding you, no idea. We really didn't. We just knew that we wanted to collect something. We needed to start somewhere. And so it was buried at the very end of our note until I saw the initial distribution. So after about 3 months, we had this really great administrator, and he got the data and he pulled it out and he displayed it in a bar graph. So again, this is what the initial distribution looked like. So 6 is our lowest functioning patients, and 24 is our highest functioning patients. So my first question to the staff was, are you just bored with this? And are you just going in and putting 3, 3, 3, 3, 3, 3, 3? For all, because the peak at 18. It's like, no, that is what our patients look like. So, we talked to them about, really recording how much help they really did need with these activities. But this was telling to me, just to see the distribution of this, and this is the function of our patients. So the thought is at the Cleveland Clinic that we see the sickest of the sick. And so that would mean that the function would be really low. And look at this. This is the patients that we're being asked to see. Look at that spike of 24s, right? So all of a sudden, I had a million questions that I wanted to ask about this data. So again, if you don't know how to ask the right question, you don't discover anything. So we had a lot of questions about the initial distribution. And so what could we ask? And so were we seeing the right patients for therapy in the hospital? You saw that peak at 24. Those are people that were independent. I like to say they met us at the door when we went to see them. We find them in the, outside. So were we seeing the right patients? And prior to that, everything we did was anecdotal. It would be the one-offs that, we got a referral on this patient that was completely independent, but we could never aggregate that information. Again, should the therapist be primarily responsible for the mobility of all of our patients? So you saw that on that slide I showed you that, between 18 and 24, that means that our patients that need a little bit of help to move. So wouldn't it be great if nurses and other members of the medical team could help participate in the mobility of those patients? And then again, were we making the correct recommendations for post-acute placement? Could we be more objective in our decisions on where patients should go? So for us, the power of this information was not only getting all of the team to collect the data, but it was having somebody that could aggregate it and then display it for us in a way that was meaningful. And so we created we've done a whole bunch of stuff to do that, but I don't go into a meeting with anybody anymore that I don't have the distribution of what their patients on that floor look like, right? Because that's how you can really drive some change. So again, it was around discharge recommendations, improving patient mobility, and guiding therapist resource utilization. So again, I showed you this slide, but again, it's powerful when I go to a nursing unit and talk about the mobility of their patients or the lack of mobility of their patients by other members of the team, and to show them what the distribution of their patients on initial eval looks like. And so this was all patients in 2012, right? This is when we were starting to tell our story about what we were getting out of this tool. And then resource utilization. Incredibly important for all of us, right? That we provide the right care to the right patients. And again, we're downstream as therapists, especially in acute care, right? We're at the mercy of any physician who wants to order our services. So in 2012, we were able to demonstrate that we had 5,419 patients, which was 12% of our consults were a score of 24. We're completely independent when we went to go see them. So we could show that 80% of them went home with no needs. They had absolutely not one rehab need. 20% did need outpatient therapy and 20% went home. So when you start to present this kind of data to administrators, it became very powerful to start to implement some change. And again, a necessary cost to the health system. And this was coming at the same time that we were putting together presentations and asking for more staff so that we could do a better job in the ICUs, right? So here we have, how many therapists does it take to take care of 12% of your population, and we're asking for more for the ICUs. So we just had to redistribute our workforce. And this is what it looked like graphically. So again, being able to display it like this was really helpful for us. And then again, with discharge recommendations, we started to see some trends in what the scores were, and depending on the setting that patients went to. So this wasn't really surprising to us. Our lowest scoring, lowest functioning patients had a recommendation or went to LTAC. Our highest scoring patients went home. And what was interesting is that the mobility scores for SNF and acute rehab were exactly the same. So again, this is back in 2012. This is our first data poll and the first time we started to look at this data, and we could see where our patients went and what their average 6-click score was. So we had lots of data. And so at this time, before Diane and I met, we had about 250,000 data points. Now we have well over 1 million on activity and mobility of our patients. But this is back in 2013. So we had a lot of data and a lot of great information. We knew the data was helping us drive operational change. I could tell in the clinic. I took this information to meetings all the time now. And I started to present it to some audiences outside of the clinic. I went to a state conference in Ohio, and I talked about driving a culture of patient mobility and using this information to help us drive that change. And then we got accepted in 2013 to speak at CSM, and it was the first time I'd ever talked about this nationally. And I remember Alan went, and I was like, oh my God, I'm so nervous that he's going to see us talk about this. But it was the first time we spoke, and that was 2013. It's 2016. This tool is now being used by over 308 hospitals in the country. So a lot of that is because of our relationship and what Diane was able to do with this. So.
Well, not just me. So one of the questions that someone showed you, all the questions we were meant to answer in our presentation, and one of them was, how did we get started? So Mary talked about the process of collecting data and realizing that it had an important story to tell and could drive some decisions. But for me, it started when I applied for a sabbatical. And here's my vision of what a sabbatical might be. Remember, I was teaching at the University of Vermont. We're 60 miles from the Canadian border, so a little different looking. I was applying for a sabbatical starting in January. And I called Alan, because Alan and I had worked together previously, as some of you know. I'm not as husband and wife or brother and sister, but as good colleagues. And as a matter of fact, I first started my relationship with Alan when I went to him and asked him to be on my dissertation committee, because I was doing a PhD at Boston University School of Public Health and in epidemiology and biostatistics. And they kept saying to me, where's the exposure and where's the disease? Where's the exposure and where's, I'm like, no, it's not about that. So I need someone who understands the language that I'm trying to use, because I was a physical therapist in a place where there were mostly physicians doing PhDs. So Alan helped me translate what I wanted to say to the committee that I had. So that started a long trajectory of working together. And he said to me, I have this group in Cleveland Clinic that I've been working with. I think it's something that's up your alley that you'd be interested in. However, I have no idea what the state of their data is. It could be a big mess. It could be nothing, but you might want to explore it. So I said, well, that sounds really interesting. So I think it started with a phone call. Mary was on the phone. Dr. Fred Frost, who is the division chief.
He's the chairman for PM&R.
The chairman for PM&R. And I believe also a couple of the people who manage the data in Mary's department. And we had an interesting phone call where we were trying to sort out what it was we were asking each other to do and what our relationship might be. And it was determined that I should perhaps go to Cleveland and meet with them. So this then turned into this. This was, it did.
Is it really Cleveland?
It really is Cleveland, and it really did look like that when I landed. So this was on the outside. I can honestly say that on the inside of Cleveland Clinic, it was warm and welcoming. It was a wonderful beginning of a relationship, even though it's not quite what I had imagined. And it's only grown from there. So we're going to tell you a little bit of story about how it's grown and what's made it work. Because one of the other questions that was on our list was not just how we got started, so this is kind of how we got started, but what are some of the barriers? And I was like, I don't want to talk about barriers. There weren't barriers. I want to talk about what helped our relationship to work to result in the outcomes that we got together. So I'm going to take it from, because my middle name is Pollyanna, as many people know, so I'm going to just talk of it from that perspective. So this is a story of different cities, different institutions, and different people coming together, although they're all in northern climes and there's no beaches. But Burlington, Vermont was where I was working at the University of Vermont when I first met Mary. I was on sabbatical, and the university offered me the opportunity to take a sabbatical. Alan was at the School of Public Health in Boston, and Mary, of course, was at Cleveland Clinic in Cleveland. But that didn't matter. The geographic dislocation and the different types of structures and people didn't really matter. As a matter of fact, it might have actually improved the vibrancy of our relationship. I'm going to start by talking about one important thing: culture. Don't you love that? Make a chair and take a seat. So Mary and I have heard this already in the room today. I'm not sure that there's even one speaker that hasn't used the word culture. And when she and I were talking about the talk that we wanted to give, we actually had a long conversation about the most important thing is the culture. So the culture actually starts, I think, from an institutional perspective in terms of their missions. And Cleveland Clinic, academic medical centers, and universities and college systems often have very intersecting missions. So they are often about education, and the primary focus is on patient care and providing excellent patient care. We educate the next generation to be excellent practitioners so that they can provide that care. That's an intersection of missions. Even though the primary focus of a place like Cleveland Clinic Health Systems is care of patients and the university isn't, we still intersect at that point. We also have missions that require us to contribute to new knowledge, and also in different ways, and we may bring different skills to meeting that mission, but it's an important intersection. And I think at that level of mission is probably the most critical in terms of the culture. And then finally, the quality improvement culture, always looking to do something better, the next best thing, how can we do things differently, and not being afraid of change and risk. So those are the cultures that we brought together.
Yeah, and I was fortunate at the main campus of the Cleveland Clinic. We had just hired a lot of new grads who had graduated with their DPT and were really interested in contributing to research. So part of the reason that we didn't have any self to them with collecting data is they wanted to do it and they wanted to be able to contribute. And so that was huge within our culture. And again, their wanting to always provide better patient care was really what drove a lot of this.
And I think most PTs, and most of, I'll say my students, that's what they want to do. They want to give better care. And I think other people have said that here today as well. So the next thing it takes is engaged people and champions. And we weren't Greek cheerleaders, but we did have that kind of culture that helped us become those engaged people and champions. And it starts with the institutional leadership. And Mary and I were having this conversation, and I said, I remember a while ago reading a story, and I believe it was maybe in the Boston Globe Sunday Magazine or New York Times or something like that, about Cleveland Clinic and the culture of improvement, and that the president of that hospital actually went around and looked at data and confronted, for example, cardiologists. You aren't up there in terms of, let's say, prescribing beta blockers for your patients who just had an MI. How come you're behind your colleagues here? What's going on? So there's a culture within Cleveland Clinic of using data to drive clinical decisions and to reduce some of the variability.
And that's part of the reason there was such a push when we had the opportunity to start collecting discrete data, when we had a documentation system or an EMR that would allow us to do that we were going to do it. And it was the physician leadership that said, we're going to figure out what it is we're going to collect. And I was like, okay, all right, we will.
When I went to visit there, I was very impressed with, I think, everyone. I met with the clinicians, I met with Mary's team and the data managers, I met with Dr. Frost. I actually went on the floors with the clinicians as they collected the data. And there was, I think, universal acceptance and actually enthusiasm for the process, right down to the frontline clinicians. So that's, I think, another important part of that culture. The data managers were amazing. I think perhaps in my conversations with other people, not from Cleveland Clinic, but that's one area where I think some places may be lacking, because it can't be up to a person who's the head of the department, like Mary, to manage the data and the spreadsheets and understand how data systems integrate. So meeting the data managers, one of whom is a physical therapist, one of whom was not, but they understood their data. They understood MediLinks, they understood Epic, they understood how the data could be integrated, and they knew what was in there. So that was another thing I did. Not only did I go on the floor with the clinicians to see how they were implementing it on the front lines, but I went and sat with the data managers, and they took me through their systems. Not that I completely integrated it all within my 2-day visit, but it was clear to me that there was really something here. So actually going back to Alan, I said, it's not a mess. I'm really impressed. There's something here. There's something to work with, and this can be really exciting.
So just as an aside, when we did our integration, when we integrated all the therapists in the system, part of our structure was to have a therapist by background who was in charge of our informatics and collecting our data and helping us figure out what we wanted our EMR to look like and how we would collect data and what we would do, how we would report on it. So that, I think, for any people that are clinical was a really key component and a great decision that, in hindsight, that we made, because it's helped us really move forward.
And she and it was Sandy and Vinoth worked directly within the department, because I know in talking to some of my other colleagues, they were like, well, we have to call down to IS and we have to get on a list, and we are last on the list, and it will probably be 3 months before they can get to our data request. It's like, wow, that's not the system that's going to be facilitative to this relationship between researchers and clinicians. And of course, we have our students who, in my experience, are always interested in working with faculty on research. That's one of the things that is particularly intriguing to many of our, and I'm talking about DPT students, not our PhD students, because of course they have to do that, but the DPT students want to. It may not be a requirement for them, but they get a lot from interacting with faculty and understanding how clinical data are used for research, not just on the front lines of clinical practice. And then, of course, our professional colleagues. So Mary going to meetings and talking to a room like this about her experience and her suggestions for moving forward, and our going and showing, okay, here's what the relationship can look like and will facilitate research, because this isn't the first time that we've talked together. Mm-hmm. We have had opportunities at CSM, and I forget where else, Innovation Summit. So we've had some experience talking together. So our professional colleagues have invited us, and we're thankful to them for doing that. So collaboration. I don't know how many of you have ever seen this slide, but we hope that the culture and the champions provide the spark. We don't want to go as far as blowing something up, but we hope they provide the spark for getting things going. And in our case, I think that they did. So our collaboration started on a fairly general level. I told you we had a phone conversation, then I was invited to come to Cleveland, and we started general conversations. We kind of knew that this suite of issues that I have here on this slide needed to be addressed. We didn't get right down to every detail immediately. However, at Cleveland Clinic, I did go and meet with the head of the IRB to talk about what would it mean to have their data given to me and what would that take. I did meet with the various people that could help me negotiate through that system. And not everyone was clear. Even Mary wasn't clear who did I need to meet with and who did I need to talk with, but everyone was extremely helpful. We talked in general about what kinds of research questions. Mary left her slide and said, we wanted to know, is this a valid and reliable tool? And that's what I heard them asking, is it a valid and reliable tool? But that's just a very general, open question. It was more about how can we answer those questions? What data do we have? And are they reasonable data for helping you to answer those questions? We needed to talk about whether this was going to take money or not. I mean, the Cleveland Clinic supported my travel to Cleveland and my stay there, which was lovely, but we needed to talk about whether there was going to be any additional funding necessary. And then, what were our various roles going to be? Who was going to have authorship? Who was going to do what in our collaboration? And what were the expected outcomes of this collaboration? So we just started in those kind of general conversations, and I went away back to another snowy, cold place, Burlington, Vermont, and had some time to really sketch out some more detail. So as we did this and started sketching out more detail, we started having a back and forth, whether it was email, whether it was phone calls, whether it was directly with Mary, or whether it was with one of the data managers, or whether it was with the IRB office at Cleveland Clinic or the IRB at University of Vermont. We started having this back and forth to really start to cement and tie down the kinds of questions that we were going to ask. And I needed to know what exactly is in those data sets, what kind of data, what does it look like, and start floating ideas. Well, we could ask this question: if you have these kind of data, do you have data on where patients come from? Do you have data on their age? Do you have data on where they're discharged to? What shape is it in? What does it look like? So a lot of back and forth. So figuring out what the data were, what types of questions we could actually get addressed, and then determining, once we figured that out, and I was able to confirm that certain kinds of data were available or not available and what shape they were in, then figuring out how to get me the data, and then negotiating kind of that data use agreement, which in my estimation at universities, sometimes they don't even know, like, what? What are you talking about? I'm like, who needs to sign this? Well, I don't know, who cares? So, okay, so figuring out those kind of things and figuring out who's going to be the primary IRB and how we're going to work out that relationship. So it took a while. How long
But
did it take
I
us?
don't know, but I would say that it was all, at least
Yeah.
on my end, it was pretty painless.
Yeah, it was
It was
painless.
really and pretty seamless, which is not, which is probably unusual for the Cleveland Clinic. I can't imagine that we just hand data over to anybody, really. And so I think part of it is that the trust that the organization had in Diane, right? She had we knew of her reputation, we met with her, she met with the team, and everybody was like, this seems like something we could do. I knew my limitations. I mean, I know what I'm good at and I know what I'm not good at. And so if it would have been up to us to get this, to get this out, we'd still, it wouldn't be. So we really needed a collaborator to be able to tell our story and to get this out.
Well, this is where that red arrow, I think, is important, because Mary may know what ability she needs, and I know I don't have the data, I don't have the patients. So wait, but there are people that have what we need, and so we just need to get together and do it. And I think it's about also not being afraid to take that risk in a relationship. And we were talking earlier about what made you trust me. Like, I don't know, I have white hair, or I don't know what it is, but I think it is that willingness to take a risk and to test out a relationship, and then finally to realize that people are going to do what they will do what they said they were going to do. So they have integrity in the system, and they don't just let things slide. So there was a lot of back and forth, as I said, on email and phone. So it wasn't something that I just went and said, okay, hand me your data, talk to you later. It was a lot of interaction and actually getting to know people in the system. So I think the final thing that we need is the desire to learn and share knowledge. And this cartoon is my desire to be well-informed is currently at odds with my desire to remain sane. And that's, I think, how I'm feeling in this political year. And so I think most of the time I'm feeling insane. So this cartoon kind of resonated with me. But we didn't feel insane working together. Our desire to learn, I like to think, started with Mary saying, we have to count something. And Atul Gawande says this in his book, Better. And it's the most simplistic thing, and I'm sure he's not the only one that's ever said it. But it resonates because this is what everyone's been talking about here. We just need to start counting something. And then, as Mary showed you, then she looked at the graphic and said, wow, look at the data. This is telling us a story. And that was just from trying to count something, not even knowing what you had. And I think we've heard that time and again today. So in order to do that, though, we have to make decisions about what kinds of data we need. So Mary talked about narrative data being an epic, discrete data versus narrative data. And there's clinical trade-offs to that. So clinicians like a rich story, and patients' stories tell us something, and they can lead us to clinical decisions. But they're not always helpful when it comes to counting. So I'll tell you a quick little story about the data that I got from Cleveland Clinic. One of the pieces of data, I said I'd like to know where patients came from. Where were they living prior to their admission? Were they living at home? Were they living at home alone? Were they in a skilled nursing facility? Where were they? So Vinoth puts together the data for me, and I get it. It's all narrative. 200,000 cases of narrative about, and here's what they said. I'll give you an example. Lives at home on the 3rd floor with 2 cats. Her son comes to visit on Sunday. So I was like, oh my God. No, yeah. So this is what therapists like, the 2nd floor, someone's there, someone's not there. So I decided, okay, we can try to figure this out. We're going to misclassify some of those cases, but let's see if we can figure out at least home or not home, or home alone versus, and so I had a poor student. Okay, so this is where students come in. I'm sure she was blind by the time she was finished. I did try to help her, but those are the kinds of decisions that were made clinically that were difficult to address in bringing in data to actually analyze it in a research way.
But we learned from that too, right? Because
the poor blind student went to Cleveland Clinic, apparently.
Because we then had the opportunity to, we no longer use MediLinks on the inpatient side as like a bolt-on for therapy. We now document in Epic. So we had the opportunity to go back and rebuild Epic and to be able to utilize flow sheet rows. And so we could take what we had learned about what information was truly necessary and use that to build a really slick, efficient, minimalistic inpatient documentation tool, which I don't think a lot of people say about when they refer to Epic. But it was because of of what we had learned with what we had done with 6 clicks.
I think the other thing about data is sometimes you have to make a decision about whether this will be a new set of data that you're going to study or whether this will be data from your routinely collected data set. And as Mary said, the 6 clicks was both. It was a new system of collecting the data that were normally collected. And I think that made it very palatable for the clinicians on the front line. And it made it easy because it was discrete data now covered in a way that it was clinically meaningful. So the kinds of data I think are also important. Recording and storing and accessing, I think Mary had an earlier slide about the ability to do that and aggregate the data. And now that this was, we did this 3 years ago, as Mary said, and it was still a lot of paper in many systems, and there may still be, but I think we're moving much more rapidly toward the EHR than was prevalent when we started this particular relationship. But figuring out what goes in the EHR, as Mary said, is critical because you want to be able to access the data and use it to count something. And if you haven't collected what you want in there, then it's not any more helpful than paper, unfortunately. So I think when you're developing a system, you really do need all the different stakeholders to come in to make some decisions, including the researchers. And then the measurement tools themselves. And for us, we've talked today about using outcomes measures, but we have to think about what those are. They have to be meaningful to clinicians. So clinicians want measurement tools that are, have evidence for reliability and validity, that they're relevant to the types of patients that they see, and they have minimal training requirements, like Mary said. So this 6 clicks fit the bill. And if they're not, if tools aren't like that, then they won't be used accurately, they'll be adapted, or they won't be used completely. We'll forget to take measurements on patients. So trying to figure out what the right tools are, I think is absolutely critical. And I think the bottom line is, in fact, less is more. So Mary's team said, we're going to collect 6 clicks. They didn't say, which of these 10 tools do you want to collect from? And you can have 5 of them. Because once you start having multiple different tools used for multiple different kinds of diagnoses, or you have 5 tools that people can use for assessing patients with stroke and 5 different tools for assessing patients with TBI, then it becomes much more difficult to aggregate data and make decisions on it. So making sure that the data are useful to people.
Yep.
And then here's out of our time together, we've now had 5 publications together in the last 3 years. So those were our outcomes. That was our goal when we started, was to actually get the word out in print about 6 Clicks. And then we kind of went on from there. We had a couple of other collaborations.
And
But I'll
some
let-
ideas in the works.
So now Mary is working on leveraging the work that we did together. So building on that initial work and relationship and now moving forward.
So yeah, so I just want to show you just one example. And so this is when I go to a talk now or a presentation within our organization, I really talk about use of 6 Clicks to provide decision support for us in the hospital setting. And how are we going to use this to make better decisions about how to provide care and to improve our operations, right? Just what we've been talking about. And the first thing I reference is that these publications, that we are talking about a tool that's valid and reliable and has been proven useful to help us make better recommendations for post-acute placement, right? Better discharge recommendations. So I make sure that I set the framework for that with whatever audience I'm speaking to. So most recently, our therapist, I was talking to them, and they said, you know what, we are noticing that we're getting more requests for pre-cert visits. This is in the acute hospital, from insurance companies that want to make sure the patient's just right before we move them to a post-acute setting. So I said, well, let's measure it. So we inserted a flow sheet row that said, is the primary reason for this visit today for a pre-cert visit? Well, lo and behold, we had 1,000 patients a month that were being asked to go see a patient solely for the purposes of doing a pre-authorization for an insurance company to move them to the next level of care. Not value added, not better for patients, but just they want to make sure that patient is packaged just right. So I said, well, what an opportunity that is.
Count something.
So we pulled the data. And so then, now we have a 6 Clicks dashboard. And so I can pull data for whatever I want. So for this purposes, I wanted to show the payers, Anthem and Humana to be exact, that the patients that we were recommending for skilled nursing on evaluation were not the patients that spontaneously recover and are independent when they get to a skilled nursing facility. That on eval, we were making good recommendations and those patients didn't change. So I could pull this dashboard and I could show them, this is the distribution of patients where the recommendation by a therapist is skilled nursing. And you see it's not the same distribution I had on that mobility slide, completely different. So it's the lower functioning patients where we're making that recommendation. And then showed them other data to show that our patients weren't changing. So again, we have initiatives with payers. So this is going to make a huge difference for us. That patients with an initial 6 Clicks score of 18 or below will not require an updated PT or OT note prior to SNF admission. That we will be able to send them to the skilled nursing facility, which we do have a relationship with, a connected care partner. And so without the pre-cert. And so, again, we'll measure it, right? And so to that point, we do truly have connected care partners that we work with in the community, skilled nursing facilities, that also collect the same data for us so that they can show that for our patients that we send to their facilities, they're measuring the same functional outcomes. So,
Yeah.
lessons learned.
So we had the people in the culture, right? Business intelligence right here. And a culture of improvement and knowledge sharing. So I think those aren't unusual out there. They're in this room and they're out there in our communities. We just have to find the right partners to make it all come together. It's not that hard. We just asked. And then we were asked for our model, and I looked at it earlier and I said, Mary, this is the same model there's nothing new in this model. It's not a model, it's the model that everyone has been talking about. There's nothing unusual about it. We doing good on time?
I think we're done.
We're done. So, thank you. You have questions? We'll just kind of... So if you have a question, raise your hand, and we have 2 young ladies in the back who will run with the with the microphone.
Jason Benechek, University of Florida and Brooks Rehabilitation in Jacksonville. So, Mary, this question, I guess, is specifically for you. There was a really great presentation, and it has to do with your conversation with the payers. I think that sounded like a very positive experience. In my experiences, I haven't had too many positive experiences. So I mean, did they buy into this fairly
What
quick?
they did, and so it didn't start with me. It started with our med ops at the clinic, at the Cleveland Clinic, had been working with the payer to figure out a better way to decrease the administrative burden for everybody, right, in moving patients between settings. And so they talked about a couple pilots that they were trying to launch, and they couldn't get anything going. It was not working. So I said, we have functional data on these patients. What if we used a 6-click score? So they asked me to come present. And so I really was careful about the information that I took. I took data that really showed that the patients that we recommend for skilled nursing don't change while they're in our care. As a matter of fact, they might get worse because we don't do a great job of mobilizing them. So I had really great data to show them that they don't spontaneously improve, that we think about, the therapists, when they're making a recommendation, really think about what we talk about it in the 4 quadrants, right? They think about the medical status, the environment, their cognition, and then function. And we had this measurement of function. And so having that data and information to show them, again, on about 1 million patients, right? We have all this data, made a difference. And they really bought in fairly quickly. And we've had our first review, and we have not missed. So the average 6-click score of the patients that we've sent without a pre-cert has been like 13.9. So we're sending appropriate patients to their facility. And so it's just been better for everyone.
You have funders up there. I'm just curious about the cost of this whole operation, and going forward, how is it going to be continue to be funded?
So I think one important acknowledgement is that my university funded my sabbatical, so that's part of the funding. I said that my trip was to Cleveland Clinic was funded by Cleveland Clinic. But one interesting story, and then the rest of it was really just blood, sweat, and tears kind of funding from within. But the one interesting story was that Mary and I were at CSM, and we were talking about the need to do a reliability study. And Mary was talking to me, we really need to do it. I agree, we really need to do it, but here's how I envision doing it. And Mary goes, that costs too much money. We'll never be able to do that. And who walks in and by that we say hello to, but Nancy White from the foundation. Nancy, sit down. Hi, how are you? We were just having this discussion. And so she said, let me think about this. There might be some money. Long story short, we were funded. So Mary was able to pull together a quick proposal because we interacted with our colleagues, and that was one of the things that I was trying to share with you, how important it is to draw people in. So we've never had any real big formal funding, but we do need to thank the APTA for that little infusion of funds to help us do the reliability study.
We have a question from the web audience. You got it? This comes from Mara Gabriel, and she was wondering if they are interested in putting 6-clicks into place at their hospital, where do they begin?
So Mary and I get a lot of emails about 6-clicks once they read the papers. How do we get it? How do we do it? And then questions about implementing it and questions about analyzing it. And we sent them to Mary Stilphen. So Mary has the answers to that question. Mary, do you want to answer that? Can you answer it, or is it too complicated? Send an email to Mary Stilphen. Other questions? Oh, there's
Hi, Carrie Wood from Endicott College. You had mentioned, and this may link with the last question from the audience, but that there are over 300 institutions now using 6-clicks. And it links me to the discussion in big data that we had. And so I'm curious if there's any formal or even informal methods of sharing the lessons learned across, not just how do we start it, but what we're doing with communication with payers, strategies to help identify the questions and really recognize that this is something that could also be used in critical access hospitals and other places, and not just the academic medical centers and the impact that could have in healthcare across the nation.
The tool is being actually, Alan, can you answer that question? No, no. You know, so right now, we are not aggregating the data from other hospitals. We're using it for our hospital. Alan and his team are distributing the tool through MediLinks, and so that's how you get the tool. So I don't know if they have the ability to aggregate the data that's coming in from other organizations, but I think it's a great suggestion.
Other questions? Okay, then,
Great,
well, thank you
thank
very
you.
much.